Hello everyone. My name is Mostafa Abdeen. I'm a resident physician at MTI University, and we will discuss brain CT imaging on today's lecture. As a future healthcare provider, it is essential to have a thorough understanding of the diagnostic tools available to us. In this session, we will explore the principles and clinical applications of brain CT imaging, which is one of the most commonly used imaging modalities for assessing various neurological conditions. By the end of this lecture, you will have a better understanding of how brain CT scans work, their indications, contraindications, risks, and benefits. Moreover, we will also discuss some simple principles of brain MRIs. However, kindly note that I am not a radiologist, so this topic does not fully fall within my range of expertise. So on this note, let's get started. So first order of business, we need to understand the proper indications for ordering a brain CT. So patients most deserving of a head CT include those who are suffering from a trauma. So if you have a patient who comes in an emergency setting, who has been a victim of a traumatic experience, and you are suspecting any skull fractures or brain injuries, please order a CT. If you are suspecting tumors on a patient who might have any symptoms of intracranial pressure, maybe they're losing weight, so please also order a CT. If you are suspecting any bleeding, maybe you're suspecting a ruptured aneurysm, which we may suspect in a patient with a sudden severe headache, then also please order a CT. If you are considering strokes and you want to exclude hemorrhagic causes of strokes, or if you're suspecting hydrocephalus, especially in a child, any diseases and malformations of the skull, then these are all good indications for you to order a CT. There are also some extra indications for a CT. These should include if you're evaluating your patient prior to surgical reconstruction, if your patient has any sort of hearing loss and you're thinking maybe the etiology is from the bones. So if you're thinking of any bone etiologies for hearing loss, then you should also order a head CT. If you want to assess the paranasal sinuses, maybe you're trying to take a biopsy and you need to guide that biopsy, so a CT scan will be very useful. If you want to assess any aneurysms or AV malformations, then a CT angiography is going to be your go-to technique. Now, since we covered some of the most important indications for CT or for head CTs, I think it is proper that before we delve into the subject that we review some of the basic anatomy before we delve into the fascinating world of brain CT imaging. So initially, we need to identify the four main lobes from a lateral view. So we need to know the occipital, parietal, temporal, and frontal lobes. And they are well indicated here by the color scheming in these imaging. So the most posterior one is the occipital lobe. This one here is the temporal lobe in green. The one in pink is the parietal lobe, while the one in yellow is the frontal lobe. And we can now see it here as well. So the blue one is the temporal lobe. The one that is most posterior is the occipital. The greenish one here is the parietal, and the yellow one is the frontal. So please, I just want you to keep your attention mainly for the central gyrus and the lateral gyrus. So this is the central gyrus, and it's well depicted here. This is the central gyrus, and it serves to separate the frontal lobe from the parietal lobe. And I also want you to keep attention for the the central sulcus. And the central sulcus serves to separate the frontal lobe from the parietal lobe. And here we have the lateral sulcus, which serves to separate the temporal lobe from the parietal and frontal occipital lobe. So these are your most important landmarks, the central and the lateral sulci, okay? And most posteriorly, as we previously said, we have the occipital lobe. So let's proceed from here. Now, if we look at a sagittal view of the brain, this will allow us to review the sites of some other important landmarks. These include the pineal gland, the pituitary gland, and the hypothalamus. So if we take a look here, so this is a sagittal view, and from this sagittal view, we can here see this is the pituitary gland, and above it is the hypothalamus. So if we zoom in a little bit, so this is the hypothalamus, this is the triangular shaped structure, and below it we have the pituitaries. We have the posterior pituitary and the anterior pituitary gland. If we go back to the original sagittal view image, we will be able to see the pineal gland, situated right here. And this is about enough of what we need to see here from this sagittal view of the brain. Now, if you're capable of identifying these landmarks on both of the images, then you probably know what you need to know to identify structures on a CT. Okay. Now, let's proceed from here and talk a little bit about the skull. I want you to be reminded that your skull is formed of 8 bones that fuse together along suture lines. I like you to remember them using the mnemonic step of 8. Now, I like this mnemonic because it reminds me the S is for the sphenoid, the T is the temporal, E is the ethmoid, P is the parietal, O and off is for occipital, F is for frontal, and it reminds me that there are 8 bones. So this reminds me that we have 2 parietals and 2 temporals. So this is how I remember the bones of the skull, by the mnemonic step of 8. The face, however, is formed of 14 paired bones. And these 14 paired bones include the mandible, the maxilla, zygoma, the palatine, the inferior nasal conchi, the lacrimal and vomer bones. Okay, so let's take a better look at the image. This is going to guide us even better. So as we said, your skull is formed of 8 bones. I like to remember them with the mnemonic step of. So here we have the S, which is the sphenoid. Here we have the T, which is the temporal. Now, I can't see the ethmoid on this one, but we can see here the parietal is quite clear, the one in orange, and then the O for the occipital and the F for the frontal. Now, if you look inside the skull, you will be able to see the main 3 fossae, the anterior fossae, anteriorly, middle in the middle, posteriorly. Here is the very famous foramen magnum, okay? Now, if you look at the bones of the face, as we said, it's formed of 14 paired bones. However, it's just all you need to identify here is the mandible, the maxilla, the zygoma, and the nasal bone. So that's about it for this image. Now, this one is a little bit more detailed. However, you just need to know the exact same structures that we previously just discussed, which are the step of 8, the sphenoid, temporal, ethmoid, parietal, occipital, and frontal bones of the skull, along with the bones of the face. Now, in the bones of the face, as we just said, we just need to know the mandible, the maxilla, the zygoma, the nasal bone, and you might even add the lacrimal bone to that because it's quite visible on this diagram, okay? So this is just what we need to know from these images. So now, since we covered the main indications for a CT, we should also cover the main contraindications for a head CT. So as some of you might know from the previous lectures, CTs use X-rays. And this simple statement, or just the simple knowledge of the fact that CTs use X-rays, should guide you to the only concern with CTs, which is the fact that CTs use a certain amount of radiation. So we usually tend to avoid scanning pregnant patients because we don't want to expose their fetuses to any sort of radiation. However, this is not an absolute contraindication. So if you're ever in the emergency room and you're suspecting that the patient might have any sort of intracranial bleeding or they are at any immediate danger, so we will not give any respect to this contraindication. We will not care whether the patient is pregnant or not. We will have to take a CT image if the patient's life is in any sort of immediate danger. So be reminded that we may use contrast for certain indications. However, we usually avoid contrast, or we always avoid contrast in cases of renal insufficiencies or allergies. Now, for a patient to have a true allergy for contrast, that is quite rare. Most patients will have what we term as a pseudo-allergy. Contrast don't really cause allergies except in a handful of patients. So now that you're going to order your CT, now that you know which patient is more worthy of a CT and which patients are contraindicated, or let's say relatively contraindicated, we need to know how should we introduce a CT, or how a CT is typically prepared for a patient. So these guidelines are usually given to patients before going to a CT, and these are general guidelines which I will just read loudly over the next few slides. Most concerns will revolve around allergies or ability to excrete contrast along with any psychological burden, especially if the patient is claustrophobic. So if a patient is about to go into the CT, we will ask them to tell us if they are pregnant, if they are allergic, especially to iodine dyes, if they have any heart condition such as heart failure, because this is all revolving around the ability to excrete the contrast, or just the fact about, for in case of heart failure, is just concerned with lying supine, as people tend to lie in a CT scan. If the patient has any diabetes, if they're taking metformin, because metformin kind of interferes with the kidney excretion. If the patient has any kidney problem, if they have asthma, if they are using any medical devices, such as a pacemaker or an insulin pump, because that might interfere with the imaging. And if the patient is claustrophobic, if they become very nervous in small spaces, because you will need to lie still in a CT scan. However, they don't need to lie still for a long time as they do in an MRI. So usually we can get a CT image from a claustrophobic patient, but an MRI would be sort of a challenge. Sometimes we might offer a sedative to help these patients just to relax, okay? If a patient is coming for a CT, now this is just basic stuff, so they should wear comfortable, loose-fitting clothes, and maybe we would give them a gown. So the metal objects, including jewelry, eyeglasses, dentures, and hairpins, all of that may affect the CT. So we ask patients to remove any metal objects before taking a CT image. And again, if we're taking a contrast dye, because contrast may cause any sort of allergies, as we said, even though it's just in a handful of patients, or maybe it would cause a lot of trouble for a patient who has any kidney problems. So we will ask the patients to fill in a consent form so that we could share the responsibility with the patient and not carry the full responsibility on our own. We ask the patients to read the form carefully and ask any questions so that this becomes a correct consent form. And after that, and yes, so you don't need any fasting for the CT, okay? Unless there is a contrast dye. So that's about it. Now, if you're giving a patient a procedure with contrast, please make sure that their kidney functions are okay. We do that around 72 hours, which is 3 days before the procedures. If they're taking a contrast, we ask them not to eat anything 4 hours before the procedure. They may drink clear liquids until the time of the scan. That would include water, black coffee, tea, apple juice, clear soda. This could form a good MCQ. So just be aware of what could be termed as clear liquids, okay? And after that, and before we get the CT, we have to secure a consent form if it is a CT with contrast. Now, as I said, a CT without contrast does not really deserve a consent, okay? And by does not mean, by the words does not deserve a consent, I mean it does not deserve a written consent. You have to ask your patients. So the following slides include several consent forms for CTs. Now, these forms will be available on your educational portal on the MTI website. So feel free to read them at your own pace, at your own convenience. I don't see the point of reading them. So by now, I think it's proper that we should discuss some noteworthy events after a CT imaging procedure. So after using a contrast dye, we should keep an eye for some side effects of pseudoallergy, such as itching, swelling, rash, shortness of breath. Also, any infection at the site of injection should warrant medical attention. So we always ask the patients to give us a call if they notice anything weird after they've gone home. Also, patients on metformin should check their kidney functions after a CT, especially if they're giving a CT with contrast. And they have to make sure that their kidney function are back to the baseline before they are able to resume metformin. So if a patient on metformin goes into a CT with contrast, please inform them that they should not resume metformin until their kidney function tests are ready, okay? So before we get into imaging, so let's take a rapid look at the common protocols for a head CT. So concerning the patient's position, a patient should be supine with the head in a head holder. Now the head should be in a tucked position for the patient's safety. And by the tucked position, we mean that the patient should tilt their chin towards the chest. And we scan from the cervical spine C1 to the top of the calvarium. And by the word calvarium, we mean the skull cap. So it's from as I said, it's from the cervical spine C1 to the top of the calvarium, or the top of the skull cap. And Concerning the contrast, just please know that there are no indications for an oral contrast, but if you are giving an injected contrast, whether it's an IV or an intrathecal one, these should be done under the supervision of a radiologist. Okay? So that's about it for the pre-phase. So before we get into the CT imaging, does anyone have any concerns or questions regarding the basic stuff we just discussed? Any questions so far? If you're okay, just send me that you're okay on the chat. I know this because we have like 30 or 32 slides of general discussion. So if you have any issues up till now, please tell me. Everyone okay? Can anyone hear me clearly? Okay, so everyone is okay up till now. Okay, so let's get to the real stuff. Let's get to the CT images. Now I know this is what you came for, so let's start delving into the images. Now, we need to look at CT brain images from the most inferior going up. As I told you previously, if you work as a radiologist, how this works is that you will be scrolling up on your mouse, and that will be moving the image from the most inferior to the most superior. So you go inferior going up. Now, whenever we're going to discuss any structures on the imaging that will show up, please keep an eye on this red line, because this red line will always help us to understand which level are we studying, okay? So the red line on the sagittal CT brain here is going to tell us which level are we studying. However, this is not showing on a radiologist's monitor. A radiologist is well experienced to know which level they are looking at just by moving the mouse, okay? So the image on the left is a normal axial CT brain, and our main objective is to identify the labeled anatomy. So if you go from the most anterior, now this is the orbit of the eye, and you can easily identify that these are the eyeballs. So this is the orbit of the eye. And behind the orbit of the eye here, we have the sphenoid sinus. Now remember, air would appear pitch black. Air would appear pitch black on a CT because it's the lowest density on the image. So this is why you would look at air sinuses and you see that they would appear as pitch black. So here the sphenoid sinus is pitch black. Also the mastoid, if you look at the mastoid air cells here labeled at E on this side and here on this side. So if you look at the mastoid air cells, they would also appear as pitch black. The canal for the external auditory meatus also would appear as pitch black. So just get the pitch black items out of the way. Just understand if you're looking at something that's filled with air, you're probably looking at a sinus. If it's opening to the environment, then you're looking at the external air meatus. And just behind the orbit, this is supposed to be the sphenoid sinus, okay? Now, going on from here, we have just to see what we have left here is the letter C, which is showing us the temporal lobe. So that's about it for the structures. So just remember them using the colors. That will be easy. So here we have the orbit. The pitch black item here, number B, is the sphenoid sinus. C is the gray item, which means that we're looking at something from the parenchyma of the brain. So this is the temporal lobe. And D is the external auditory meatus. And E, we have the mastoid air cells. And F, can someone identify from this image here, like look at the line. So from this image here, can someone tell me, are we looking at the occipital lobe, or are we looking at the cerebellum, looking at the red line? What are we looking at? Can someone tell me from the chat box? Is the cerebellum. Perfect, Ala Ahmed, perfect. So because we see this red line here is not crossing through the occipital lobe, because here's the occipital lobe, it's crossing through the cerebellum. So that's why this image here, or the F here, is actually pointing at the cerebellum, not the occipital lobe. So again, this red line is very important because it should help you identify which structures are you expecting to see on this image, okay? Now, if we move a little bit superior, if you go a little bit up, now we're scrolling up with our mouse. Now we are above the eye level. So we're not supposed to see the orbits here, okay? And how do we know that? Because we can't see any of the darkness of the orbit. So now we understand that we are above the eye level. The orbit is no longer evident. So if we start from the most anterior, now we can see which of the following labeled structures that we need to identify. Please remember that colors help us identify the structures. So if the structure is white, I would start thinking that I'm looking at a bone. If it's pitch black, I'll start thinking of air. If it's gray, I'll start thinking of the brain, or maybe it's a vessel that we're supposed to identify. So here we have A that is grayish, and by looking at the red line, A is going through the frontal lobe. And B, you get no points for knowing that this white structure is a bone, and since it's frontal, this is supposed to be the frontal bone. C here is the dorsum sella. Now, the dorsum sella is a square-shaped process of the sphenoid bone. Just remember it that this is the rectangular, or let's say it appears rectangular, but from another perspective, it's supposed to be square-shaped. Okay, so this is the rectangular shape here on the CT. This is the dorsum sella, and D just below it. This circular structure here, just below it, we're looking at the basilar artery. Okay, and here at E, we are looking at the letter E here. We are looking at the temporal lobe. Now, F, can anyone, just using the previous image, can anyone tell me what F should be? Now, I purposely took it. No, it's not opening. No, it's not opening to the exterior. See, external erythromeatus should open externally. So what are these? Can anyone tell me? Mastoid, perfect.
The sphenoid sinus.
The mastoid, yes, perfect. The mastoid. We're looking at the mastoid air cells, perfect, because they're not opening to the external environment. And below here we have G. So can someone tell me, looking at the red line here, should G be the occipital lobe or the cerebellum? Any idea?
Cerebellum.
Cerebellum, perfect. So we're looking at the cerebellum, perfect. Thank you to people who responded on the mic and people who responded on the chat box. So let's proceed from here. So by now we should realize that each slide, we're just moving upward with each image. Now, here we just need to identify the structures as well. So we look at the red line here, and we'll notice that anteriorly it's crossing the frontal lobe. Now, the structure number B here, this is the Sylvian fissure. Now, you can see it's much darker than its surroundings. Now, remember, the Sylvian fissure is just a large diagonal fissure on the lateral surface of the brain. It serves to separate the temporal lobe. Now, can someone tell me another name for the Sylvian fissure? Any idea? I think we already mentioned it.
Lateral fissure.
Lateral fissure. Any other answers? Huh? Okay, I just wanted to confuse you, but yes, it's the lateral sulcus. Okay, that's the same as we're looking at. So we're looking at the Sylvian fissure here, or the lateral sulcus. That's supposed to be the same in the realm of imaging. We should be identifying them as the same. So B here is the Sylvian fissure. C, as we look aside here, that's the temporal lobe. So that's the frontal lobe, and separated by the Sylvian fissure or the lateral sulcus, we are supposed to see here the letter C, which is the temporal lobe. Okay. And then we see this star-like structure, which looks like the Star of David with the six angles. And this star-like structure is the suprasellar cistern. Now, the suprasellar cistern is located above the sella turcica, and it's under the hypothalamus. This is, as I said, it's just roughly shaped as a Star of David or a 6-point star, and just need to identify. If you see this 6-point star, just know that this is the suprasellar cistern, okay? And then we have the structure at E here, which is the midbrain. F is pointing towards the fourth ventricle, this circular dark area. And G here, if we're looking at the red line, we're still looking at the cerebellar hemisphere. So at this point, we can identify the frontal lobe, the temporal lobe, but still the occipital lobe is not showing on this image, okay? So any questions so far? So as I said, the main objective or the main thing that you should be doing whenever you're looking at an image is that you have to understand which color is which and what is the level that we are looking at. So any questions so far? Everyone okay? Okay. Let's proceed from here. So again, still going up. Now at this point here, so A here is pointing towards this whitish triangular part. It's like a very small triangle here, which is the falx cerebri. Now, the falx cerebri is in fact a very large crescent shaped fold of the dura. Now, normally it should descend in the longitudinal fissure between the cerebral hemispheres. It should separate the two. Hemispheres and support the dural sinuses. Okay, so but here, because we're looking from an axial point of view, so it should only appear to us as this small triangular part. Now B here is pointing at, as we look at the red line, is pointing at the frontal lobe. C is showing us the anterior horn of the lateral ventricle. Now remember, the lateral ventricle is, does anyone know what sort of material is filling the ventricles? Any idea? What sort of material should be filling the ventricles, the third ventricle, the fourth ventricle, the lateral ventricle? What sort of materials? The CSF, correct. Ala Zaid said the CSF, and Ala Ammar, perfect. So here it should be filled with the CSF. Now because this isn't parenchyma, so it should gray, it's not bone, it shouldn't be white. It's not air, so it's not pitch black. But however, water still has a low density. So this is why it should appear darker than its surroundings. So whenever you're looking at these darker points within the brain parenchyma, then you should suspect something that should be filled with fluid. Now, normally at this level, if you know your anatomy, then normally at this level, you should be looking here at the anterior horns of the lateral ventricle. Now, if you go down to D, you should be seeing the third ventricle, and a little bit lower at the E. Now, this is what we term as the quadrigeminal cistern. Now, the quadrigeminal cistern is just a dilatation of the subarachnoid space. And it just extends between layers of, if I'm not mistaken, someone should Google this up, but it just extends between the layers of the tila chorioidae and the third ventricle, and it contains some of the great cerebral vein and the pineal gland. Okay, so this is what we term as the quadrigeminal cistern. And F, again, look at the red line, it's going here at the cerebellum. So F, this should be the cerebellum. And most posteriorly here, we could be able to see the occipital lobe, since the red line actually starts visualizing the occipital lobe at this part. So this is a normal CT of the brain, or normal CAT scan of the brain. Whenever we look at the CAT scan, we should be looking, now CT, whether you say CT or CAT scan, it's the same thing. Both are computed tomography. Now, whenever you're looking at a normal CT of the brain, you should be assessing the ventricle size. Now, this is the normal size of the ventricles. So please just see as much pictures of this, so you would be able to identify when the ventricles are dilated. So does anyone know any famous condition which has very dilated ventricles? Now, remember, these ventricles are hydrocephalus. Perfect. So the ventricles are supposed to be filled with CSF. So they are, if they are dilated, it means that we are incapable of getting rid of the CSF, or we are producing a lot of CSF. And both cases we see in hydrocephalus. Now, another question: which age group will we be seeing hydrocephalus? Any idea? Which age group will present with hydrocephalus? Any idea? Infants, maybe children. Let's say children, not infants, because you can see it in children as well. So we're looking at the younger population whenever we're thinking of hydrocephalus, okay? So here the ventricles are normal sized. Now, in this image, you can see the gray versus white distinction. Now, what do we mean by the gray versus white distinction? So white matter is located centrally in these images, and they should appear blacker than the gray matter. So when we say gray versus white distinction, it means that we can, and maybe because you're looking from a zoom screen, this wouldn't be very evident, but whenever you look at any CT scan, you'll start noticing that the internal parts are darker than the external parts. And by that, and that is what we mean when we say gray versus white distinction. And I know this is counterintuitive, but please remember that the white is central, the white matter is central and darker on the CT scan, because a lot of people mistake this, okay? Now, the third thing we need to confirm is that the midline is straight. So both hemispheres are normal. Nothing is pressuring any of the hemispheres. If the midline is not straight, then we will most probably be looking at an image which has a tumor, because that's the only thing that I can think of at this point that would cause a mass effect to push the midline on one of the sides, okay? And then we start looking at the sulci, and this is very important. This is gonna save you a lot of time if you just realize this. You need to look at the sulci and make sure that they're symmetrical on both sides. So you have to look at these lines and compare them on both sides, because this is going to help you very much, especially when we start talking about hemorrhages. because usually, maybe, well, like not just usually, but most of the time, this is going to be the only way that will help you know whether this patient has a hemorrhage or not. Okay. And lastly, we just make sure whether the skull is intact or not. We just take a look at the white borders and make sure that they are continuous. And we see if the patient has any sort of scalp edema. Now, please remind me, scalp edema means that there is some sort of water that should be on the exterior of the brain or the exterior of the CT image. Now, remind me, in a scalp edema sense, this is water. What color should I be looking for if I'm looking for scalp edema? What color should I be looking for if I'm looking for scalp edema? Black, perfect. So I'd be looking for a darker color, something in the same shade as this here in the CSF. So it's not as dark as the air here. It's just as not as black as the air here, but darker than the rest of the structures like the CSF in this image. Okay. So again, the CT is just a game of colors. You have to know which colors you're looking at. And if you do a fast revision of your anatomy, this shouldn't really trouble you. Now, this is a slide that I added. It's not really on your, it's not really part of the lecture. However, I thought it would be useful for us to get a simple revision before we get into a discussion about hematomas, epidural hematomas, subdural hematomas, subarachnoid hemorrhages, and so on. Okay, so the image here below is giving us, this is a good image because it's giving us an idea of how a subdural hematoma looks like, how an epidural hematoma looks like. Now, the easiest way to look at this is just remember that the subdural hematoma will have a crescent shape. It looks something like a banana. The epidural hematoma will have a biconvex shape, and it looks something like a lemon. Now, the subarachnoids will be running here between the sulci. So this is why I said it's very important for you to compare the sulci on both sides and appreciate the colors within the sulci to make sure whether you're looking at a hemorrhage or not. And the DAI here is just standing for diffuse axonal injury, but that's not part of today's discussion. Now, let's take a look at the subarachnoid hemorrhage, the picture that's up here. Now, remember, the subarachnoid hemorrhage is an acute bleeding under the arachnoid. That's why it's called subarachnoid. Now, remember, you have a few layers covering your brain, including the arachnoid. So if you have a bleeding under the arachnoid, that's when you get a subarachnoid hemorrhage. Most commonly, we see this in a patient who has a rupture of an aneurysm, and most commonly, we see this in a setting of trauma. So as I said, in radiology, the history really matters. So you might suspect a subarachnoid hemorrhage in the setting of trauma. We will be also discussing it in detail in quite a few moments. Now, if you're looking at an epidural hematoma, which is the image that's about here, now we're seeing the epidural hematoma is just bleeding in the virtual space between the dura and the skull. So here's the skull, and this is a virtual space, which means that it doesn't exist normally. However, it should start existing, or it is capable of existing, whenever it needs to capacitate or whenever it needs to withhold fluid such as blood. So in cases of epidural hematoma, okay? And as I said, if you're looking at an epidural hematoma, it should appear on an image something that looks like a lemon, and we'll start looking at these images shortly, okay? So an epidural hematoma, we would usually see that in the context of a fracture of the temporal bone, especially if there's any rupture of the middle meningeal artery. Now, that's the most important artery to remember in the cases of epidural hematoma, the middle meningeal artery. And I don't know, is there an image here of cerebral contusions? Can't see one. Okay, I think we will see some CT images of contusions as we proceed further. So let's start a little bit by talking about epidural hematoma. So as I said, we're looking for a biconvex structure that looks like a lemon, as we see here on this side of the image. Now, as I said, epidural hematomas, we're mostly thinking of patients who had a rupture of their middle meningeal arteries. These patients on their history will have something which we call as a lucid interval. Does anyone know what a lucid interval is? Any idea? You can use the chat box. So usually, okay, so maybe you haven't no one discussed that with you yet. So if we're looking at an epidural hematoma, again, as I said, patients have what we call as a lucid interval. So this patient would suffer a trauma, and after the trauma, they would become unconscious. However, they would have a period of consciousness, which we call the lucid interval, before they fall back into being unconscious. So this is a classical history of a patient who has an epidural hematoma. They have this lemon-shaped or lens-shaped blood collection or hematoma here, which would guide us to know that we're looking at an epidural hematoma. So again, it says epidural hematoma, usually associated with the skull fracture, occurs impact of fractures of the calvarium, which is the skull cap. The fractured bones lacerate a dural artery or a venous sinus. The most important thing to know here is the middle meningeal artery. Now, the blood from the ruptured vessel collects between the skull and the dura, and as I said, this is just a potential space. Okay. Now, the subdural hematoma, on the other hand, is going to give you this more crescent or banana shape that we see here on the periphery. Now, please note it's not as white as the bones, okay? It is not as white as the bones. Now, the crescent shape here, or the crescent shape here that we're looking at for the subdural hematoma, that's the classical picture whenever we're looking at a subdural hematoma. However, sometimes we could get a subdural hematoma that's surrounding the tentorium. Now, that would look something like a fork here at the posterior part of the brain. So if you see a structure, a white structure on a CT that looks like a fork at the posterior part of the brain, then you should also be thinking this patient has some sort of subdural hematoma. Now, the most important thing to know about subdural hematoma is that usually we're thinking that the main cause is a rupture of the bridging veins. Now, remember this word, bridging veins. And we usually see them, for the sake of history, we usually see them in elderly patients and alcoholics. Now, I want you to note something important here. Now, because this is not a potential space, now this isn't the same. Can I just ask everyone to close their videos? Okay, thank you. Now, as I said, now because this isn't a potential space, this is actually interfering with the brain parenchyma here in the subdural hematoma. So just a few, or like a small collection of blood, it doesn't have to be that big, just a small collection of blood will be enough for us to notice that there is a midline shift. Now, this is supposed to be the midline where I'm going through with my mouse. However, excuse me, I just skipped the slide. However, if you look here, the midline is shifted, it's not midline. Why so? Because we have a mass on this side. Just always remember to comment on the midline whenever you see any mass-like structure that's pushing it to the side, okay? So, again, before I proceed, does anyone have any questions? Any questions so far? You can use the chat box, and as I said previously, whatever slide you feel like I need to repeat, I always have different ways to explain the same thing. So feel comfortable to ask if you feel any sort of confusion. If you feel that everything is okay, so just please confirm on the chat box. Bridging veins again, please. Okay, so bridging veins. So as I said, just whenever we're speaking in the context of subdural hematomas, now if you want to know, or you're thinking, okay, what is the main etiology behind this blood collection? What is the main cause that we have all this blood here? Now, usually we're thinking that this is an elderly patient or an alcoholic, and because what do elderly patients and alcoholic have in common? They're more susceptible to falling. So usually these patients would fall, and whenever they fall, now they don't have falls that are severe enough to cause a break or a fracture in the skull bone, but it causes enough friction between the layers of the brain that this friction would cause pressure on the bridging veins, and these bridging veins would rupture and allow for a collection of blood on this side. And because we're speaking about veins, it means this collection is slow. So this is why you would see a lot of patients who have had several subdural hematomas and have never presented to an emergency department, especially if they are old. And this is why it's very common for us to see what we call a chronic subdural hematoma, and I'll be showing you an image of that shortly. But that's because, as I told you, these are usually elderly patients and alcoholics who get a fall that is not very severe, usually won't cause any visible effects. So they usually neglect the incident up until they have been through 2 or 3 or 4 falls, and enough bridging veins have ruptured, and enough of them have caused collection of blood here, so that the patient would present after that to the emergency room. Okay, so is that clear by now? Any clearer? Here, you're welcome. So again, let's proceed. So this is an acute subdural. So what we're supposed to see is an acute subdural hematoma and edema on the left side. So remember, whenever you're looking at an image, it's like you're looking at a mirror. So this is, I know this is your right hand, but this is the patient's left side. So now we're looking at the left side. So the red arrow here is supposed to be showing us a subdural hematoma. Now, as I said, this is a blood collection within the coverings of the brain. So it makes no sense for a subdural hematoma or an epidural hematoma to be anywhere other than the periphery. So if you're looking for a blood collection, especially in the realms of subdural hematoma and epidural hematoma, then you're looking at the periphery. Except, yeah, like I would say the only exception in this case would be if you have a blood collection around the tentorium, especially in subdural hematoma. And again, you have something that looks like a fork at the posterior part. But other than that, if you're looking at a subdural or an epidural collection, you just look at the periphery for any abnormal whiteness, because that's how blood would appear like at the periphery. Okay. Now, a subarachnoid hemorrhage, however, as I said, is bleeding. Is supposed to be bleeding that we would see by comparing the different or comparing sulci on both sides. So this is this is how we should be guided whenever we're looking at for a subdural hematoma. Now, as you can see on the right hand side, you can visualize some of the sulci, but on the left hand side, you're not able to see the opposite ones. Okay, and remember, a subarachnoid hemorrhage is just bleeding in the space between the brain and its surrounding membrane, the subarachnoid space. So usually in the history of these patients, you will get a patient who says that they have some sort of sudden severe headache. Okay, and just to like anchor this in your mind, the main complaint that all patients with a subarachnoid hemorrhage would present with is saying that they're having the worst headache of their life. Now, if you ask them to rate the pain that they're going through out of 10, they'll tell you the pain is 11 or 12 out of 10. This is the worst pain that they ever felt. Okay, so just to easily identify this on an image, always just compare the sulci on both imaging and keep an eye on for the differences in colors. Okay. Now, it says here that this patient also has edema. Now, how do we understand that this patient also has edema? Because something is causing a shift of the midline towards the right side. Now, that's not the subarachnoid hemorrhage. It's the edema that's surrounding the subarachnoid hemorrhage. So you can see here the white lines here are signifying the subarachnoid hemorrhage. Now, the increased darkness around them, that's the edema that's surrounding it, and that's what's causing the midline shift that we're seeing around here. Okay, now let's go to the following image. Now here we're seeing a chronic subdural hematoma, and as I said, patients who get a subdural hematoma, we're thinking of patients who are elderly patients or alcoholic patients, and the common between both is that they both fall repeatedly, and because they might not have any symptoms, they might not have any breakage or any fracture in the skull bone. It is very possible for a patient with a subdural hematoma to not present to the emergency room. So this is why we could start seeing chronic subdural hematomas on image CTs. Now, remember, blood should appear white. You should see white if you're looking at a blood collection. However, if you're looking at the periphery of an image and now it's dark, then just realize that you're looking at a chronic subdural hematoma, which is indicated by the red arrow. Okay. Now, after you've done looking at the periphery, please start comparing the sulci. Now, as you're looking at the sulci, you can see here on this side, you can see the dark areas for the sulci. Now, you should look at the mirroring parts, and then you start seeing whiteness in these areas. Now, this whiteness is in these areas. This should make you think, okay, this patient probably has bleeding or has blood in the subarachnoid space. So now, do they have any sort of edema? If I want to make sure if they have any edema, I should start looking at the midline. Now, since I don't see any issues with the midline, then I should notice, oh, this patient doesn't have an edema, but they have some subarachnoid bleeding because I cannot see mirroring images of the sulci. Okay. So before I proceed, everyone okay? because I know these images sometimes can be confusing, and I know some people would rather suffer in silence than ask publicly. So just want you to remember that you can choose me from the menu below at the text box and send me a question privately if you ever feel that you're embarrassed to ask out loud, okay? So let's continue. So now we just want to talk a little bit about subarachnoid hemorrhages. Now remember, the most common cause of subarachnoid hemorrhage is trauma. This is the most common cause. So if you see a patient who's just suffered any sort of trauma, let that be a motor vehicle collision, let that be a patient falling from a height. However, even though that is the most common cause of subarachnoid hemorrhage, it's an easy cause to think that the patient has hemorrhage after they've underwent any sort of trauma. Now, the most important cause that you should keep an eye for, because a lot of physicians tend to miss it, is the possibility or the patient might have a ruptured berry aneurysm, okay? It's called a berry aneurysm. I'm gonna write it here on the chat box. So you should suspect, maybe if a patient comes to you in the ER, within the emergency room, and the patient has a headache which they describe as the worst headache that they've ever had, and doesn't have to be congenital, doesn't have to be, no. And the patient says that they have the worst headache that they've ever had in their life, and you ask them, have you been in any sort of traumatic experience, whether they've had a hit to the head, a fall, or whatever? And they said, no, please don't exclude subarachnoid hemorrhage. Please order a CT for that patient and start comparing the sulci on both sides, okay? Now, subarachnoid hemorrhage, again, is just a term that we use for any bleeding that's between the pia and the arachnoid matter. However, we just need to compare the sulci on both sides. And now this image here is just very easy to compare. Now you should compare these darker sulci, and then look at the other side. We have them filled with white material. And now these high density blood, the areas where the red arrows are pointing, this is showing us that there is a subarachnoid hemorrhage, or they are filled with blood, because this patient has a subarachnoid hemorrhage. So let's proceed. Okay, so again, I'm just going to read this slide. I think we've went through enough concerning subarachnoid hemorrhages. So it says here that the blood shows as white on the CTs. It says here that the anterior communicating artery aneurysm has burst, flooding the basal structures under the brain, outside the brain parenchyma, but will occasionally empty into the ventricle. So this patient had a very recent rupture of the anterior communicating artery. So we caught the brain image just before the blood started filling into the ventricles. And it says this is the typical bat wing shape, just above the green line. So this looks like a bat wing. Okay, you don't have to write this on your exam. You don't have to say, oh, this is the anterior communicating artery and the aneurysm has burst and this is flooding the basal structures. This is not what we're looking for in the exam. Just should be able to identify that you're looking at an axial CT image of the brain, and this is a subarachnoid hemorrhage, and that the ventricles haven't yet been filled. That's just enough for you to know, okay? So what happens if the blood fills the ventricles? Now remember, the ventricles are normally filled with the CSF, and the CSF is very close in its structure to water, so that's why it should be dark. Now, if you're looking at the ventricles and you see that they are filled with whiteness, or something that is a white fluid that doesn't have any identified borders, especially if it's surrounded by darker edema, that's also a good sign for you to look for. Now, if you're looking at ventricles which are which are filled with white, it means that you're looking at most likely looking at blood-filled ventricles. Okay. Okay. Before we proceed, since we are done with the main hemorrhages, please tell me that everyone just tell me that you're okay with this, because I don't think I'll be addressing the hemorrhages again. So please tell me if you have any questions. So I just address them before we move for any further. Everything is clear? Okay, good to know. Okay. So now let's take a look at the cerebral hemorrhages. So this slide shows a parenchymal hemorrhage on the left basal ganglia. with like a mild surrounding vasogenic edema. You can look at the part where the white arrows are pointing. So because I said blood should appear white, so this is why we have a white collection, and it's surrounded by a vasogenic edema. Now, a vasogenic cerebral edema, whenever we say that term, vasogenic cerebral edema, means that we're looking at a cerebral edema in which the blood-brain barrier is disrupted. So most likely we see this sort of edema around brain tumors, not cerebral hemorrhages, but we can see it around cerebral hemorrhages as well. And it's also in the cases of vasogenic edema. If you're looking at a vasogenic edema, you would note that the gray to white matter differentiation should be maintained. It means that if you're looking at the central part, the darker part, which should be the white matter, like in here, for example, you should be able to notice that there are darker parts on the inside and also brighter part on the outside. It's even at the site of the hemorrhage, you should be able to notice that it's still here is brighter and it's darker a little bit on the outside. Okay. So it's maintained, as I said, it's maintained in these cases of edema. And here, it just wants you to know that the basal ganglia, the pons, and the cerebellum are very common causes or very common areas of bleeding, especially if a patient has hypertension. Okay, so if we have a hypertensive patient, especially if it's a hypertensive emergency. Now we're speaking about patients who have blood pressures above 180. Sometimes some books would identify them as patients above 220 even. So if you're looking at a patient with these shocking blood pressure numbers, then you should look out for cerebral hemorrhages, okay? Especially at the basal ganglia, pons, and cerebellum. So this image here is showing us a hemorrhagic stroke. Now, for those out there who don't remember what a stroke is an acute neurological condition. Now, this means that this patient has a sort of disruption in their cerebral perfusion. So this disruption in the cerebral perfusion, or this cutting off of the blood supply to the brain, can either be due to ischemia, which means that the blood is not arriving to the brain, or it may be due to hemorrhage, which means that the blood is escaping the vessels before entering to the parts which it's supposed to perfuse. Now, whenever we're looking at hemorrhagic strokes or strokes because of hemorrhage, just remember that they can be intracerebral or subarachnoid. Now, we discussed the subarachnoid ones. Now, we're looking at the intracerebral ones. And also just remember that for cases of strokes, just look in the history, or in the patient's history, just look out for patients who have hypertension or any cardiovascular disease. Now, in the history of a patient who has a stroke, they're usually going to tell you that they have acute onset of neurological deficits. So they may say the patient has hemiparesis, any change of sensation. However, so whenever we look at a patient who has a stroke, or we're suspecting that they have a stroke, we have to order a CT, because this allows us to distinguish or to be able to differentiate between ischemic and hemorrhagic strokes. Now, if you take a non-contrast head CT and the patient has blood on the non-contrast head CT, it means that the patient has a hemorrhagic stroke. You will be able to identify it. However, if you have a patient that you're suspecting they have a stroke and you cannot visualize blood on the CT, does anyone have any idea what should we do? Now, I've been presented with a patient who has sudden onset of hemiparesis, and everything on the physical examination is pointing towards that this patient has a stroke. Now, I ordered a brain CT and the brain CT came back normal. So can someone tell me what is the next order of business? What should I do? Well, an MRI takes a lot of time. And if you cut off the blood supply for a brain for around, if I remember correctly, around 5 minutes, then you're going to permanently lose function. So you shouldn't really wait on for an MRI. So what should I do if I see that the CT is not confirming my diagnosis? Any idea? No, not going to give them contrast. Well, I'm going to behave as if this is an ischemic stroke, because the ischemic stroke should appear normal on a CT. So this is the main purpose of a CT whenever you see a patient with a stroke. So if the patient's physical examination and their history confirm a stroke, we're using a CT to differentiate whether this is an ischemic stroke or a hemorrhagic stroke. We're not using it to guide our to disqualify strokes from the whole differential. Okay, so strokes are still on the differential, but you're doing a CT just to see whether this is a hemorrhagic stroke or an ischemic stroke. Okay, so if I get a CT for a patient for whom I'm suspecting a stroke and I don't see hemorrhage, then this is an ischemic stroke. If I see hemorrhage, then this is a hemorrhagic stroke. This is very important because the management of a hemorrhagic stroke is very different from the management of an ischemic stroke. And if you mix your management, you're going to kill your patient. So it's very important to order a CT for these patients. Okay. Now, this patient here has a right cerebellar infarct. Now, as I said, the cerebellum here, we're looking at a patient. Now we can see the orbits. So we're looking at a lower level of the brain, and we're looking posteriorly. Now, remember the red line at these lower levels was going through the cerebellum. So this is the cerebellum. It's not the posterior lobe of the brain. So, and again, you're looking at something that's supposed to be, whenever you're looking at a radiological image, it's like looking at a mirror. So this is supposed to be the right side. So this is a right cerebellar infarct. So maybe you're telling me, maybe you're asking yourself, does that not mean that whenever we're looking at a patient who has an ischemic stroke, does that mean that an ischemic stroke should appear like this on a CT? No, this appears after a long time. This isn't an acute imaging, okay? This appears after a long time. The word infarct means that this part is already dead. So this is not what we're looking at in cases of an ischemic stroke, okay? So this patient has a cerebellar infarct, so it means that they had a stroke previously, and now they underwent the normal process of death of this part of the cerebellum, okay? So infarcts are initially ill-defined, with lower attenuation, which means lower density. So you're looking at something that has a darker gray appearance. So whenever you're looking at an image like this, and the history suggests that the patient has some sort of previous stroke, and you look at the color and it's not homogeneous gray, there's a darker part like this, then you should suspect that the patient has some sort of infarct, okay? So chronic infarct are black, like CSF, because the tissue lost from the neuronal cell. Remember, infarction means death. So the cells are dead and they liquefy, they turn into fluid. So that's why they become darker color like the CSF, okay? And let's proceed from here. So this patient here, they say they have a subacute infarction. So the difference between the image before this, the one with the normal infarct, and the subacute infarction, is that the subacute infarcts are well defined. We can easily identify which area is infarcted. While here, the borders are not really uniform in a sense, okay? So this is a patient who has a subacute, infarction. And it's just the same patient, or like the patient, it's not the same patient as the image before, but it's just any patient who had an infarction, like had an event, and 5 to 7 days after the event, you start to see this geographic appearance. And remember, this would cause a mass effect. So by the word mass effect, what do I mean by that when I say that the patient has a mass effect? How should that appear on a CT image? When I say mass effect, what should you be looking at on a CT image? Midline is shifted. Perfect. So when I say mass effect, perfect, I'm looking at the midline, and here's the midline is sort of shifted because of the mass effect. Perfect. Ala amr. Okay. So I think we're done with like around 50 slides. How long have we been on this session? So I think we've been here for an hour. So would you like to take a 5 minutes break? We can take a 5 minutes break, and we will resume at 8:05, okay? So see you in 5 minutes. So I think we can resume now. We had a 5-minute break. So I think we can resume from where we just paused. So here, this is showing us a patient who had a stroke, and it's post-craniotomy for decompression. Now, A craniotomy. Okay, before I proceed, can everyone hear me clearly? I just don't want to assume that everyone is hearing me. Can everyone hear me at this point? Can you hear me clearly? Clear, okay. So as I said, this is a patient who had a stroke and it's a post-craniotomy. How do we know that this is a post-craniotomy? Just look at the green arrow. Now you can see a discontinuation of the skull and it's uniform. So this is a patient who had a craniotomy, which means that we took off or we tried to discontinue their skull bone just to allow for the extra or the exceeding pressure within the brain to have more space. We don't want the brain to suffer within a confined space. So that's why we do a craniotomy, just to allow the brain to get more space. Especially after a stroke, the patient is undergoing any sort of edema. So we're trying to give them more space for their brain. Okay. So this patient has a big blunt stroke on the left. So this is your right-hand side. Now you're looking at a mirror. Now the stroke should appear as the darker side. This is what we're looking at. This is the darker part of the, because of the stroke. And this fragment here is where the craniotomy was performed. Okay, let's talk a little bit about hydrocephalus or hydrocephalus. Both pronunciations are correct. Now, hydrocephalus is a problem with the ratio of production of CSF. It means that there is a mismatch between the CSF production and its reabsorption. Now, we're going to see this most frequently in children. What you need to do now is just observe how widened the ventricles are. Now, this wasn't on the original slide, so I just added it so you can get to appreciate the normal size of the normal ventricles. Now look at these ventricles. This is not normal. They shouldn't be this widened, okay? So if you see very wide ventricles and they're filled with darkness, it means that they're filled with CSF. Then you should suspect this patient has a problem, whether it's their ability, whether they're producing CSF excessively or they are unable to reabsorb CSF efficiently, okay? Now, this patient here, they have an intracranial tumor. Now, these intracranial tumors usually present with focal neurological deficit, and this makes sense. It's just because you have a certain growth within your brain, that it be this one maybe. So this intracranial tumor, because this growth is pressuring on its surrounding parenchyma or the surrounding parenchyma of the brain. Now, remember, the brain serves to coordinate and serves to initiate most or like, let's say the 99% of our actions and movement. So if you have something impeding on a part of a brain, that means that you will start to have a sort of a neurological deficit. Sometimes these patients would present with abnormal electrical activity because the electrical current isn't passing as uniformly as it should. This is why these patients could get seizures, and they could just have the blunt normal effect of pressure inside their skulls, which would present as headache, okay? Now, an important thing to keep in mind, please, whenever you're looking at a brain tumor, is to remember that brain tumors will be surrounded by a vasogenic cerebral edema. And as we said, a vasogenic cerebral edema is just a cerebral edema in which the blood-brain barrier is disrupted. So we can see here the darkness that's surrounding. You can see here the darkness that's surrounding the tumor. So this is how you, if you're looking at an image and you just want to be sure that you're looking at a tumor, just also it's fairly easy to identify, but also add an extra layer of confirmation by looking for the vasogenic cerebral edema. Okay. Now we look here. This patient has a meningioma. Now a meningioma is fairly easy to identify because whenever you look at a meningioma, we're looking at something that is usually peripheral, like this here. And most patients, or the patients that you will see in their history, they'll be middle-aged women. And because most images you'll get for meningioma will be calcified meningiomas. So that's why you will see them as white as the brain cap, okay, or as the skull, okay? So you'll see something calcified just as the skull, but however, it's at the periphery, then you should start suspecting that this patient might have a meningioma, okay? So here are some other images. So this image here, this is a normal brain CT. Now just, again, appreciate the sulci, okay, on the both sides. Now start looking here, start see whiteness in here, whiteness surrounding in here. And then you start noticing this patient has some sort of hemorrhage within their parenchyma. Now we're mostly looking here at a subarachnoid hemorrhage. Now we're looking at the images A, B, and C. We're looking here at a subacute infarct. Now remember, a subacute infarct is darker in color and it's well defined. We said it's subacute because can easily identify the borders that you're looking at. Now, if we look at the images D, E, and F, it's the same patient. However, we gave them some contrast. Now, the extra added benefit of the contrast is that now we're capable of visualizing the brain gyri, because you can see now that these white lines are enabling us to see where the gyri are, and it's making the infarct much more visible, and it's easier for us to identify which anatomical part is affected on this patient. Now, a lot of neurologists get a lot of fun from understanding which part of the brain is infarcted just by physical examination. However, on actual practice, you always have to get a CT to know which part of the brain is infarcted. Cannot just solely rely on physical examination. Again, so above here, we can see a patient who has, now, I don't really like the images above, and I'll tell you why shortly. So just let's discuss the images below. So the images below, the one on the right and the left, both are the same. However, this one has a contrast added to it. Now, can someone tell me, what are we looking at this image? Can someone tell me? Is this, I'm going to give you, before you answer, I'm going to give you some hint. Look at the midline. Take a good look at the midline. Now, the midline is shifted, okay? Now, before you answer, this, we're looking at something that could cause a midline shift. And you can see it here. So can someone tell me what are we looking at? Any idea? It's well defined. A mass, perfect. Any idea what kind of, is this like a tumor? Is anyone thinking this is more of a tumor? It's a tumor, okay. Because you're looking at a mass that's causing a midline shift, and it's surrounded by vasogenic edema, especially could be more visible here on its borders, like around here, and going on around the borders here. You see the vasogenic edema. So now we're looking at a mass that's causing a midline shift. Now, what gave it away was the midline shift. That's what gave it away for me. If I didn't spot the midline shift, I would have been very confused. Now, why do I not like the images above? Because they don't really state whether these images are with contrast or without, okay? So if we're looking at the images above now, and if we said that these images have a contrast, then I would have said that this white color here, I would have said that this white color here and everything abnormal of about the images, I would have said that we could easily refer these to or say that these are just because of the contrast. Now, this whiteness here, the whiteness below here, and this areas of whiteness here and whiteness here, I could have said, okay, this is most probably just normal contrast. However, if this patient is not taking any contrast, I would have said that the whiteness on the periphery is hemorrhage, and I would have said that this is a calcification. So because this image is not stating whether this is with contrast or not, I'm not really able to tell you exactly what am I looking at, okay? So if this appears in your exam, ask whether this has contrast or not. So it's, as I said, if it doesn't have contrast, then you would say that these are hemorrhages at the periphery, and you would say that this is a calcification. If it has contrast, then this is just normal. So that's about it for CT. So before we proceed, any questions before we go into MRIs? Any questions so far? Okay, I'll assume someone said, how will I be asked about this in the exam? You'll probably be asked to, probably be given a history and be asked to identify what are you looking at. So is this a tumor? Is this a hemorrhage? Is this so on? Because if I'll be fair with you, CTs are way too complex for an undergrad. if I'm going to be like honest with you. Now, this isn't a formal announcement. I'm just saying this as a colleague. I think CTs are way too complex for undergrads. But however, I think that up until now, from my current understanding, is that you will just be asked to identify the image, like what are you looking at? So this is an axial brain CT, and then you should be capable of saying, oh, so I see here there's a mass and there's a midline shift, and probably that's more than enough to go. You don't need more than that. Okay. So let's discuss a little bit about MRIs. So MRIs, the word MRI stands for magnetic resonance imaging. Now, it's a fairly complex device in the way it works, but in short, the patient is placed in a magnetic field and we send a radio frequency wave and then we turn it off. And once we turn it off, the patient emits a signal as a response to the radio frequency wave that they've been subjected to. And we receive the signal coming from the patient and we put it in the computer, and the computer is able to construct an image. So here you can see like a simplified version of the physics of MRI. So it says before the imaging starts. So remember, you have hydrogen. All of us have hydrogen in different parts of our body, but mainly MRI is concerned with the hydrogen in the water and the fat. So you have hydrogen protons inside your body, and these hydrogen protons, you can think of them as bar magnets. Now, you know the bar magnets, the one that look like a bar of chocolate, and part of it is looking to the north and the others to the south. Now we can start thinking of these hydrogen ions as bar magnets, and normally, without undergoing an MRI, these bar magnets are looking at different directions because there's no external magnetic field. There's nothing pushing them to be directed to a certain direction. However, whenever you are subjected to an MRI, now the MRI is a magnetic resonance imaging. Now we have a very strong field, and this strong field will start aligning the hydrogen ions in your fat and water with the magnetic field. Now the small bar magnets will start collectively will start identifying north and south as the same direction. Now, after you've turned on the magnet, you will start to send a radio frequency pulse. It's not a radio wave. It's not a wave. It's a radio frequency pulse, but let's say it's a wave. So you send a radio wave, and the radio wave is transmitted through your body. Now, what does this radio wave do, or what's the function of the radio wave? Now, it's just designed to tip the magnetization away from the longitudinal axis. So I'll try to simplify this. So what we're trying to do is that so now each of these magnets, because of the magnetic field, is looking, let's say, this way and this way. So all of them, because of the magnetic field, are looking at the same positions. Now, when you send a radio frequency pulse, what you do is that you kind of push these magnets away from their comfortable position. So they start going like this. They're tilted away. That's what you're trying to do, okay? Now, after you send the radio frequency pulse and you put these hydrogen ions or these hydrogen protons in an uncomfortable position, and you shut the radio frequency wave, what they will do is that they'll try to go back to their comfortable position. They'll try to align back to the magnetic field. Now, what the computer does is that it records the time taken by these hydrogen protons to go back to its comfortable position or to go back to its normal alignment within the magnetic field. And this time, using complex algorithms on the computer, is how the computer is capable of creating the magnetic resonance imaging, or the MRI. So just to say this as simple as possible. So you have a lot of hydrogen protons in your body. Each of them is like a bar magnet. Whenever you apply the magnetic field of the MRI, these bar magnets will identify north and south they will collectively identify north and south. So then they will be aligned with the magnetic field that's coming from the MRI. Then we'll try to make these hydrogen protons uncomfortable. So we'll send a radio wave, and this radio wave will start tilting these hydrogen protons away from the magnetic field. When you shut off the radio frequency wave, they'll go back to their normal position. Now, the time it takes them to go back to their normal position feeds the computer with information about the positions of every hydrogen ion within your body. And the computer uses this information to construct an image. And that image is what we call an MRI. Now, I know the physics is complex because MRI physics is a full subject on its own. So definitely this is just a very simplistic overview. However, if you just understand the fact that this relies on hydrogen protons and the magnetic resonance imaging is a big magnet and just sends a radio wave and then it shuts down the radio wave and the computer uses the information to create an image. If you know this little bits of and pieces of information, then you're good to go. So if anyone is slightly confused about the very simplified version, just please tell me. If everyone is okay, also please tell me that you're okay, because I know physics is probably not the area of strength for medical students. So just please tell me if you're okay with this. Is anyone confused? Everyone okay? Okay, so Abdul Qadir says they're okay. Everyone else okay? Okay, clear. Okay, that's good to go. Okay, that's good to know. So here we need to know what are the advantages of an MRI. Now notice that whenever we were speaking of CTs and X-rays, both were relying on the technology of the X-rays, which means that both were relying on ionizing radiation. Now MRI does not rely on ionizing radiation, so that's why we're not really concerned about pregnant patients or concerned about the radiation effects. So there are no ionizing radiations, and usually you can get a lot from an MRI without a contrast. Yes, you will have to rely on contrast in many situations, but you won't need as much contrast as you would in a CT, or not as in many situations as you would in a CT. Now, in MRIs, we have a lot of sequences, and by the word sequence is very similar to the windows in the CTs. So we just give different, we adjust the MRI settings differently just to get a good look at different tissues. So if we want to, maybe if you're suspecting that the problem is with the parenchyma, then you're going to use a specific sequence that's going to enhance the parenchyma over the other structures and so on. So as I said, we're not gonna rely on IV contrast as heavily as we do in the CTs. And because we're not using contrast, it means that we're not going to see any allergies or pseudo allergies, and we're not concerned about the renal function. And also, pregnancy is not a contraindication. So can someone, before we proceed, can someone tell me, is pregnancy a full contraindication or a relative contraindication for CT? Full contraindication or relative? A relative contraindication, yes. Because if a patient is in an emergent situation and they're pregnant, we're still going to do a CT. Okay. So here it says, what are the caveats of MR imaging, or caveats means the limitations or where the MRI is not very functional. So it says it's very sensitive to body movements. That's why we have to ask the patient to stay still for a very long time. Now, if the patient maybe itches, moves, whatever, we're going to have to repeat the image, or we're going to get a very hazy image that's not going to be useful in our diagnosis. And it produces a lot of noise during the examination. And here we don't mean, by the word noise, we don't mean noise in the image, because I know a lot of you using photo editing applications or so on would think this is referring to the image. No, it just means noise by the literal sense of noise. It's just very loud, okay? It takes a lot of time. It's difficult to perform if a patient is claustrophobic. Now, imagine if someone is afraid of being in confined spaces. Now we're going to put them in the MRI or in the MRI machine, and the MRI machine is just like being put in a tomb. It's just like any claustrophobic patient's nightmare. Just going to put them there and ask them not to move. They're going to hear very loud noises. So usually if a patient is claustrophobic, if they're not sedated, I don't think you can ever get an MRI image from them. It's very expensive and it takes a lot of time. And that's just, please note that the idea that it takes a lot of time means that we are incapable of using it in emergency situations. So I know we're going to show you some MRI images of patients who are having a recent stroke or patients who are having an hemorrhage. However, if you're working in an emergency department, do not order an MRI if you're suspecting a patient has hemorrhage and they need emergent attention, because this takes a long time and you're probably going to kill your patient if you wait that long, okay? And it's also expensive, which means that most hospitals don't have an MRI. So usually we rely more heavily on CT. It's less sensitive for subarachnoid hemorrhage. It's less sensitive for calcifications, and relatively insensitive for bony cortical abnormalities. Now, the thing is, we usually like to use MRI for soft tissue, not for bones. Bones X-rays are more than efficient. And it says people with metallic implants should not be scanned. Now, any idea why anyone with a metallic implant should not be scanned? And why do we ask patients going to an MRI to take off their jewelry and their metal items? Why? Any idea? The magnetic waves, exactly. It's a magnet. So if someone has a magnetic implant, this is just a, I don't know, this is a sort of a terrible movie. I would not want to watch that. Okay. So again, so now before we go into the MRI imaging, we just need to know that 3 important sequences, which are the T1, T2, and T3. And sequences means that these are 3 different settings which we give the machine. And by giving them, or by giving the machine these settings, we get different looks at the brain. It means that it will focus on certain parts and give less focus to the other parts, okay? So the T1 image or the T1 sequence, this is the standard one. So usually we use the T1 because this is the standard sequence. What it does, a T1 is formed, or like the word T1 is actually formed of 2 things, which are TR and TE. So TR is the relaxation time, the time for relaxation, and the TE is the excitation time, which is the time for excitation. Now, why did I go into all this boring physics that I went through at the start? It's just to make sense of this. So whenever you're getting a T1 sequence, it means that you send the radio frequency wave for a short time. It means that you have a short excitation time, and it takes the hydrogen protons a short time, or it takes the hydrogen protons a short time to relax, this is what we mean by the relaxation time, okay? So a T1 sequence, you're not putting on the beam for a long time, so it takes the protons a short time to get back to their normal alignment. So it gives us this image or the sequence, which we call the T1, okay? Now the T1, whenever you're looking at a T1 image, you will start seeing the darker substances, and the darker substances, or whatever could appear as dark on an MRI from a T1 sequence, will be stuff like inflammation, water, or any rapidly flowing fluid. So here, because this is where the CSF is, so CSF is just like water. So when you're looking here at this image, so this is a T1, so this should appear as dark because water appears dark on a T1 image. Inflammation should also appear dark, along with any rapidly flowing fluid. And by rapidly flowing fluid, I mean blood within the vessels. And even though blood is generally more dense than normal water, but the idea here is that blood in vessels is flowing very fast, and it's because it's flowing very fast, it's not allowing the radio frequency beam or the radio wave to cause any change in its alignment. So that's why the MRI starts reading it as black, okay, because it's moving quite fast, okay? So again, whenever you're looking at a T1 image, the black parts are inflammation, water, and rapidly flowing fluid. I'm gonna write it for you because I think this is what you need to know. Okay, so a T1, dark, you're looking at water and rapidly flowing fluid and inflammation. Okay, just write these down. This is important for you to know. If you're looking at something that is bright, however, you're probably looking at blood, which is not moving, or you're looking at fat. Okay, so this is what you're looking at whenever you're looking at a T1 image. This is important for you, so you could be able to identify structures on an MRI. Okay, so here this is just telling us about the MRI imaging techniques, a T1 weighted MRI. This is the standard basic scan. It's particularly in differentiating fat and from water. Now, remember, I told you the MRI scan works on the hydrogen protons in fat and water. So this is the main thing that the MRI is actually differentiating on every image, okay? With water being darker and fat being brighter. So a contrast agent is also commonly used with the T1, with scans before and after contrast is given. In the brain, a T1 weighted scan provides good gray matter, white matter contrast, means that we're very capable of visualizing the gray matter versus the white matter. And I think you can easily do that looking at this image, okay? Now let's proceed from here. Oh, no, sorry, you can't do that on this image. Sorry, excuse me for that. Okay, you can do it on this. This is a T2, and this is where you can separate the white from the gray. Excuse me, I don't know how I said that, okay? So here you can see this is the white matter and this is the gray matter, okay? The other one here is just showing the cortex. So just excuse me for the short lapse. So again, so this is a T2 sequence. And whenever we're looking at a T2 sequence, now the difference here is that we are having a longer time for excitation and a longer time for relaxation, okay? So the wave or the radio frequency beam on this T2 sequence or on this setting is set to work for a longer time and allow longer time for relaxation. Now this here, the difference here that you need to know is which structures are bright and which structures are dark. Now the bright ones will be water and inflammation and fat, while the dark ones will be just any rapidly moving fluid, okay? So whenever you look at a T2 image, you're gonna notice that the CSF is white. So whenever you look at the ventricles, you're gonna notice that the CSF is white. So this is a good anchor for you to know a T2 sequence. However, this can sometimes, if you are working in radiology, futuristically, just forget about this, because this is the main, like mostly whenever they want to confuse radiology students, what they do is that they find situations where the ventricles would be white and ask students whether this is a T2 or T1 image. But for your level, just whenever you look at the CSF and you see that it's white, just think that this is a T2 sequence. After you graduate, forget about this. Just don't rely on it for the rest of your clinical practice, okay? So as I said, different sequences are just only different settings for the computer, and it just allows us to look at certain parts and not look at the others. Now, the third sequence that we need to know is the flare. And the flare means fluid attenuation inversion recovery. I don't think this is, you need to know what it stands for. Just remember that it just means the word flare. Now, flare, what it does is that it suppresses the signals generated by any fluids. So it means that whenever you look at the CSF or any stagnant fluid, it's just going to appear as dark. So unwanted signals from the CSF in the brain is going to look darker on the MRI. We use it in cerebral MRI for edema. So really good for edema because it's gonna make it easier for us to see a patient who has edema. So again, fluid attenuation, inversion recovery. This is the same thing we just said. It also says it's just good for patients who has MS or multiple sclerosis. Now here we need to compare the three modalities, the T1, the T2, and the flare. Now the T1, T2, and the flare, we need to understand how certain things are going to look under each of these sequences. Now, if you're looking at the T1, which is here, you're going to notice that the CSF is darker, okay? Now, if you look at the CSF in the T2, it's going to be white. If you look at the flare, it's also going to be dark. So this is an easy way for you to differentiate T1 and flare from T2. T2 has white CSF. Now we start looking at the T1 and the flare. Now we need to know how can we distinguish between both of them. Now it's fairly easy if you look at the white matter. Now if you look at the white matter here, the central white matter, you're just going to notice that on the T1, it's much lighter than here on the flare, which is much darker, okay? So this is like a very basic way for you to be able to identify. However, if you're asked to compare, you need to know these structures, these 5 structures, that we need to know how to compare them. So just remember, the CSF is dark on the T1 and the flare. It's bright on the T2. The white matter, if you look at the white matter, it's only going to be light on the T1. It's darker on the T2 and the flare. If you look at the cortex, which means we're looking at the outer parts, okay? So if you're looking at the cortex, you're going to notice that they are gray if you're looking at the T1. However, if you're looking at the T2 and the flare, you're going to notice that they are much lighter. So these outer portions are much lighter, and even on the flare, way much lighter on the flare, okay? Here we can't see the bone marrow, but the fat within the bone marrow should be bright on a T1. It should be also bright on a T2 on a flare. Inflammation, and this is very important. Please remember this. Inflammation is dark on a T1 and bright on a T2 on a flare. This is very important for you to remember. So again, as a comparison, just to remember, the CSF is dark on a flare and a T1. So we're looking at a flare and a T1. CSF is supposed to be dark. So we're looking at the ventricles, and within them, the CSF is dark. So these opposing banana-like structures, they have darkness within them. So that's the CSF. But if you're looking at the T2, now we're looking at a brighter image. So this is the CSF here. So this is the T2 image. Now, if you're looking at the white matter at the T2, it's going to be much darker. If you're looking at it here in the context of a flare image, it is still dark. However, it's very bright here on a T1. Okay. The cortex on a T1 is gray, but it is relatively lighter on a flare and a T2. Okay. So these are three imaging modalities that you need to identify. You have to know which items are darker and which items are brighter. That's about it. That's what you need to know about the T1, T2, and the flare. Okay. So going forward, for the remaining part of this lecture, the main agenda involves identifying anatomical structures on an MRI, and we're going to have a few case examples. So just use this to refresh on your brainstem anatomy. So this is the spinal cord, and above it here we have the brainstem. The brainstem is formed from the medulla, the pons, and the midbrain. Okay. So before we proceed, can someone tell me, is this a T1, a T2, or a flare image? Any idea? T1, T2, flare. Someone tell me, T1, T2, flare. Okay, someone said flare. Why are you thinking flare? Okay, people who said flare, please tell me, why are you thinking flare? Give me any reasoning. They say because the white matter is darker. Okay, but the white matter is also darker on the T2. The white matter is also darker on the T2. So why are we still thinking that this is a flare? Because it's not very dark. Okay. CSF is not white. Where's the CSF on this image? We can't visualize any of the ventricles. This is the midbrain. See, it's labeled midbrain. So these are not the ventricles. So where is the CSF? Now, this is why I said, or why I started my my introduction into this by saying that whenever you're looking, we want to identify this as a flare image, you just have to see the CSF somewhere before you proceed, because whenever you're comparing a T2 and a flare, it's actually quite difficult whenever you're looking at an image. So just be comfortable saying, if you're not seeing the CSF, if the CSF is not quite evident for you, just be comfortable saying that we are looking at a T2. That's what you need to know. That's first. Now I'm going to move back to the slide, which has the 3. Now, please take a very good look at this image. Take a very good look at this image, because now I'm going to move from this image to this. Now, this is the T2. Okay, this is the T2. Look at the T2. Look at this. Okay, now again, look at the flare. Can you see the flare from here? Now, after you look at the flare, please, again, look at this. Now revise yourself. Is this more of a T2 or a flare? Huh? T2 or flare? What are you thinking? Any idea? Okay, this is a T2. Because again, see, this is a T2 image. And it's normal for it to have this whiteness on the periphery. This is a T2 image. Same image, just looking at a T2. Okay, so moving forward, I'm just gonna, again, we're just gonna always take a look at the line here. It's gonna tell us which structures are we looking at. So here we're starting from the most inferior and then we're going up. Now, the main objective here is just for us to identify the anatomy. Now, because I know a lot of you are going to get this confused, especially if they give you any arrows on the exam. Now, the part that is most peripheral here, so see, please follow the cursor carefully. So the part that is most peripheral here, and I'm going also, again, here, I'm bordering it on this side. This is the temporal lobe, okay? If you go interior to the temporal lobe, that's the insula, okay? So the insula is here. This is the part that interior to the temporal lobe. So the temporal lobe is supposed to be most peripheral. But the CSF in the picture above is black. Oh, no, I'm not relying on the picture above. No, I don't care about that. This picture, this is probably not even the same patient. It's probably not even the same patient. Someone told me that they looked at the CSF within this image and they assumed from that, but this is not the same patient. This is just used to identify where we are at the image. Okay, I get where the confusion's from. Okay, so that's probably on us. So as I said, this is okay. Sorry for the confusion. Now I get why you guys got confused. For a moment there, I was puzzled. So as I said, this is the temporal lobe. This is one that's the most on the most outer part, and this is the insula. That's more internal to it. Now, if you look here, it's going through a part of the cerebellum. Now, this is the part of the cerebellum that is going through. This is the vermis of the cerebellum. And here's the midbrain. Okay, you see both the midbrain. And here we can see the MCA, or the middle cerebral artery. Now, remember, whenever we're looking at images which have rapidly moving fluid, especially on these images, the rapidly moving fluid does not get enough time to be picked up by the magnetic resonance imaging. So that's why these images, or the rapidly moving fluid, will appear as dark, whether you're looking at a T1 or even a T2, both of them. So that's why the middle cerebral artery, because it contains blood, should appear as dark. And here, most anteriorly, this is your frontal lobe. So again, here we have the frontal lobes, very frontal, okay? This is your temporal lobe. This is the border of the temporal lobe. And interior to the temporal lobe here, we should have the insula. This is the midbrain. This is the vermis from the cerebellum, okay? So now we're moving a little bit more upward. Sorry, a little bit downward at this point. So we're moving a little bit down. So now we're moving a little bit down, and then we should start look at this image. So here, we're supposed to identify. I don't think the levels here are very correct. I don't think the levels on the slides are very correct. I'll have to revise, because I don't, but I'll have to revise with, okay. So if we look on this side here, we have the temporal lobe, okay? This is the temporal lobe on the sides, and then the basilar artery and the ICA, or the internal carotid arteries. Now, basilar artery or internal carotid artery both have fast flowing fluids. So that's why these dots appear dark, because they have fast flowing fluids. Now, again, this is the basilar, these are the internal carotids, okay? Below them here, we have the pons. This is the pons. And then we should see here see these two lines here. These are supposed to be showing us the cerebellar peduncles. And below that, we have the fourth ventricle. Okay, moving forward, or below, according to the diagram above. Now, here we're supposed to see the cerebellum very posteriorly. Now, if you look at the cerebellum, now this is the vermis. The vermis is the part that's most anterior. And on the peripheries, most posterior and lateral, so say posterior lateral, we have the cerebellar hemispheres. In front of them here, we have the medulla. And then, as we said, the vertebral arteries are supposed to be appearing as these black parts, okay? So that's what we're looking at. Okay. Now this is the most superior part, a section from the most superior part. Now here we're only supposed to see the frontal and the parietal lobes, just the frontal and the parietal lobes. And we should be just able to identify the central sulcus, which is here. This is what we're looking at. So this is just the most important distinction in this image, just identifying the central sulcus, okay? Okay, now here, this is correct on a scientific basis. However, we would not order an MRI for a patient in an emergent setting with a stroke. But in reality, yes, an MRI would show a stroke much faster than a CT, because you can see this is a CT scan of a brain, and as you look, there's nothing wrong with it. But this is the exact same patient with an MRI taken. And if you look at the MRI here, you can just easily start to identify the patient or the stroke on the patient, okay? So it says that the stroke would show much earlier. That's the take-home message, that a stroke would show much earlier on an MRI before the CT. Now, this is a normal view of the brain. So can someone tell me, is this T1, T2, or flare? Now, this should be fairly easy at this point. T1, T2, flare. Huh? Now, Hazem is saying T2, Ala Zaid is saying T2. So can someone give me a reasoning? Why are we saying that this is T2? Any reasoning? Huh? Any reasoning? CSF is white. Perfect. That's what we're looking at. Okay, perfect. Okay. So again, here we're just speaking a little bit more about the T2 flare. Now, the T2 flare view negates the CSF, which allows a more accurate view of the brain structure. However, T2 shows most pathology in the brain as white and doesn't differentiate well between ischemia, tissue damage, and bleeding. So if you want to know what are the downfalls of using a flare image, is that you won't be able to differentiate between ischemia, bleeding, and tissue damage. Everything appears as white. So this is a patient who has a new stroke and a T2 flare. And as we said, T2 flare doesn't allow us to easily differentiate between ischemia and bleeding. So tells you if a patient has a stroke, it would usually show up as white on the T2. So this area that's being marked by the green line, that's what we're looking at here, the stroke on a T2 flare. Now, this patient has an old stroke. Now, usually an old stroke would start to cystify and develop firm borders. So here, this is what we're looking at, this image. Now, before we end this discussion, we just need to talk about, lastly, about two tumors. Now we need to talk about the glioblastoma multiforme. Now remember, a glioblastoma multiforme peaks in the mid-60s. So a patient should be in their 60s and maybe in their late 50s. And it's the most common malignant brain tumor. So this is a tumor that has a very short course. So if a patient gets a glioblastoma multiforme and they have not been managed, you would usually die within weeks. And if we manage the patient, the median survival time, if I remember correctly, I think is around 15 months. Okay, so this isn't a patient that is probably not a patient that's going to live on for long. So we need to just be able to identify the glioblastoma, because the difference between managing it and not managing it is also like around 15 months. So that's also in the benefit of the patient. So when you look at it on an MRI, you'll see that it's an irregularly shaped tumor, as you can see here. It's also, you could say it's inhomogeneous, and inhomogeneous means that it's not all of it is white, not all of it is gray. There's a mix of colors in this image. Okay, and if you if you're using a CT, I can't see it here quite clearly, but it should be surrounded by vasogenic edema on a CT. Now remember, this is a mass. So if I want to make sure that I'm looking at a mass, I should look at the midline. Now this midline is clearly shifted. Okay, this midline is clearly shifted. So that's making us indicate that this is a mass. Now, as I said, it's very inhomogeneous, and it's not just that it's inhomogeneous, but if also you look at this image here, it has a necrotic core on the pathology. Now, if you look at the image here, this necrotic core should appear as more hypo-intense on these imaging, while the hypo-intense mean that it should appear darker, while the peripheries should appear more hyper-intense or more whiter on the periphery. Okay, but the most important thing that you should look for is that it's not homogeneous, means that there are like a lot of different colors within it, has irregular borders, there's a midline shift. These are like the main points that you should look for if you're looking at a glioblastoma multiforme. And if you are looking at the case or the history, you're looking at a patient who's probably in their mid-60s. Okay. Now these are this is how a meningioma should look like. Now, as you see, it's much more it has a much more identified border on these images. Whether any sort of imaging is going to give us this more well-identified borders, and it's more homogeneous. And it says here that it's most amenable to operative resection, which means that it's much easier to operate on in a patient who has a meningioma than it is to operate on a patient who has a glioblastoma multiforme.